All right, that's good enough. This morning we'll be looking at another core fundamental chapter, patient assessment. It is a module as well, just like airway management. So it's a module by itself. Very important chapter because this forms the framework of your assessment as an EMS responder. So you must have a sequential way to assess your patient in the pre-hospital setting. So this chapter combines everything, combines airway management, it combines your assessment of specific emergencies. Everything is combined in this particular chapter. So chapter 9, patient assessment. Let's go. Introduction. Patient assessment is very important. EMTs must master the patient assessment process. Patient assessment is used to some degree in every patient encounter. So every patient that you interact with, you will perform a patient assessment on that patient. The patient assessment algorithm for EMS responders have 5 main parts. So there are 5 main parts of the patient assessment algorithm. Within each section of the patient assessment algorithm, there are things that must be considered and there are things that must be done. So each area has specific things that you must consider or do for the patient. So the 5 main parts are the scene size up, primary assessment, history taking, secondary assessment, and reassessment. All areas are important. The most important area, though, is the primary assessment. The reason why the primary assessment is the most important area, because this is the area of the patient assessment algorithm in which you make contact with the patient. So this is where you make contact, identify life threats, and address them. Rarely does one sign or symptom show you the patient's status or underlying problem. So we must be able to differentiate the difference between a symptom and a sign. So symptom is subjective information. This is what the patient tells you. What is it that the patient is complaining of? Headache, difficulty breathing, chest pressure, palpitation. What is it that the patient is complaining of? That's a symptom. A sign is more objective, so it's objective information. It's based on your observation. So a sign is what you can see, what you hear, what you smell, and what can be measured. That's a sign. Anything you're able to see, hear, smell, and what can be measured, you will consider that a sign. Now, let's start with the first section of the patient assessment algorithm, the scene size up phase. Now, within the scene size up, there are specific things that must be considered and specific things that must be done. So, scene size up, your evaluation of the conditions in which you will be operating. You need to maintain situational awareness because a scene is a very dynamic environment, so it constantly changes. Scene size up combines an understanding of the situation and conditions prior to responding. The dispatcher's basic information, you need to consider that. So the dispatcher is going to give you info as it relates to the type of situation, and you need to use your observational skills when you arrive on the scene, because sometimes the information that you get from dispatch, that's not what you find when you reach on location. Now, the first thing that we need to ensure in the scene size up is that the scene is safe. So the scene needs to be safe for you, your crew, your unit, patient, and bystanders. Issues can range from minor difficulties to major dangers. Do not enter until the scene is safe for you and your team. Typically, the way you enter an area is the way you will leave. Wear high visibility safety vests on the roadways, especially at nights. Now, things that you need to consider. You need to consider difficult terrain, traffic safety issues, environmental conditions. So if you're in an environment that is excessively hot or cold, the patient will be excessively hot or cold as well. If appropriate, help to protect bystanders from becoming patients. And there are numerous things that can make a scene unsafe. Quite a few things will make the scene unsafe for you to enter. Can be issues with crowd. It can be hazards that are present. Right? So you can have hazards that are present. Can be a motor vehicle accident scene where there is dangling power lines. Can be gas spill from a motor vehicle accident. So there are numerous things that can make the scene unsafe. Your goal is to assess what is present and then determine what would be the most appropriate resources to make that scene safe for you to function effectively. If appropriate, help protect bystanders from becoming patients. Hazards range from extreme weather conditions to the threat of physical violence. An emergency scene is a dynamically changing environment. If the scene is unsafe, make it safe if possible. If this is not possible, move to a safe location. All right, now let me backtrack a bit. So, if it is high angle or special rescue situation, then you're gonna need a fire team with rescue training. For oil spill, again, that's gonna be the fire department. If there's a dangling power line, then the power company has to cut the power in that line before you can make contact with the patient. If you have any knowledge that it is a possible crime scene or violent situation, police must be on location before you can make any type of contact with that patient. So law enforcement would be dispatched first to the location. They will secure the scene. Once the scene is secured, the law enforcement then contacts the EMS unit and said the scene is clear for you to come in. Crowd control is the law enforcement as well. That's their responsibility to deal with crowd control. Understand that a crowd on a scene is very unpredictable. And at no point in time, you should allow a crowd to encircle you while you're functioning in the scene. Never allow that to happen. And if there is someone on the location showing signs of aggression towards you or your crew members, you need to manage your distance. That's one. So you need to pay attention between the distance between you and that individual. You should not be in a position of disadvantage, and you should never square up with that person. So you need to cut an angle in which the person has to follow you if they are aggressive. That's what you want. You don't want to square up. So the bottom line for your scene size up is we do not put our personal safety at risk for any patient. So if something is present on location that makes the scene unsafe, we do not enter that scene until it is cleared for us to function without any risk to our personal safety and our crew members, patient and then bystanders. So a dead EMT cannot help anyone, and an injured EMT is a nuisance. Personal safety first. So that's your scene size up. Ensure the scene is safe, that's one. Two, and it doesn't have to be in any specific order. Two, you determine the mechanism of injury or nature of illness. The mechanism of injury is specific to your trauma patients. It is the way in which the injury occurs. So what caused the injury? Was it a fall? Did they get stabbed? Was the patient shot? Did the patient get hit with a board? Whatever caused the injury is the mechanism of injury. And when we start to focus on injury, we're talking about forces applied to the body. So when forces are applied to the body, if the body is not able to spread that force out or dissipate that force, the force becomes more concentrated, and then it results in soft tissue injury. So the better the body is able to spread force out, the less damage will occur. So that's the mechanism. So when we focus on the mechanism of injury, we need to think about the type of force that is being applied to the body, and where it was applied to the body, and what type of structures are found within that area of the body. And a mechanism can be localized or it can be diffused. So you can have a localized mechanism and it can be diffused. An example of that would be a patient is hit with a board on the forearm. The forearm gets soft tissue injury or the forearm fractures. That's a localized mechanism because it's specific to the forearm. So that's where the injury is. It's specific, localized. Another example, patient in a mango tree lose their balance, or a branch break away and they fall more than 3 times their height to the ground. That patient would have a diffuse mechanism because the force has been transferred throughout the body. It dissipated. So the possibility for multiple trauma now exists for that patient. Why is this important? It is important for us to determine what type of mechanism it is in terms of it being localized or diffuse, because If we consider the mechanism to be diffused, meaning the possibility for multiple trauma exists, then we will treat this patient as if the patient has a spinal injury until it is ruled out in the hospital. If the mechanism is localized, then we will focus on our ABCs and then focus on the injured area, the localized area. So that's the importance of the mechanism of injury. The nature of illness is specific to medical problems or medical illnesses or medical complaints. So it is whatever the patient complained of, their chief complaint. Are they having chest pain, chest pressure, difficulty breathing, nausea, vomiting, severe headache, palpitations? Whatever the chief complaint is the nature of illness for the medical conditions. Now, fragile and easily injured areas include the brain, the spinal cord, and the eyes. And when we talk about trauma, there are two common types of trauma. They are not the only types of trauma, but the two most common types will be blunt force trauma and penetrating trauma. So blunt force trauma, the force occurs over a broad area. The skin is usually not broken. Tissues and organs below the area of impact may be damaged. For penetrating trauma, the force of the injury occurs at a small point of contact between the skin and the object. Open wound with a high potential for infection exists. In the pre-hospital setting, or primary concern is bleeding control. Secondary, we think about infection control. So primary concern is controlling blood loss. Secondary, we think about infection. In other words, we do not do wound cleaning in the field. Not a part of pre-hospital care. For medical patients, determine the nature of illness. Now, similarities between the MOI and NOI. Both require you to search for clues. Now, when it comes to the nature of illness, which is specific to your medical patients, it is a chief complaint. This information, you can get it directly from the patient. You can get it from bystanders. You can get it from family members, or you can get it from the environment that you find the patient in. If you have a medical patient in which you cannot get any information from this patient or family members or bystanders or from the scene, you pay close attention to your patient. So observe the patient closely and ensure that you check the patient's pupil reaction, you check the patient's pulse oximetry, and you check the patient's blood sugar. So these checks must be included in your vital signs when you're checking them. Be aware of scenes with more than one patient with similar signs and symptoms. And usually, when you have a scene with multiple patients having similar signs and symptoms, you're thinking about a hazardous material situation and you're thinking about food poisoning. Now, once you have deemed a situation hazardous material, you should be so far away from that scene with your unit that you need a binoculars to see the location. That's how far you need to be. Do you have a question, Mr. Jones?
Yes, sir. Just asking to repeat the things we should check for if we can't get any information from patient, family, or bystanders.
Okay. If you have a patient, medical patient, in which the patient is not able to communicate with you, you're not getting appropriate information from family or bystanders, you will pay close attention to the patient. So you look at the patient. Make sure you do your hands-on assessments on the patient. When you're going to obtain your vitals for this patient, it should include your pupil reaction. So you need to see the patient's pupil reaction. You need to pay attention to the pulse oximetry for this patient, and you need to look at the blood sugar. All right, now with your hazardous material situation, as I was saying, if you suspect that it's a hazardous material incident, your unit should be at a distance that you need a binoculars to see the scene. A hazmat specialist or technician will be required, and that's going to be a hazmat team, usually from the fire department. In Jamaica, it's NEPA. They will be sent to that location. The role of that technician or specialist is to designate the hot zone, the warm zone, and the cold zone for that situation. The hot zone or red zone is where the hazardous material is highly concentrated. The warm zone or yellow zone is going to be the area where the patient is decontaminated. The cold zone, which can be green or blue, is going to be where EMS is waiting to receive that patient that is decontaminated. So we do not make contact with the patient until the patient is decontaminated. In Jamaica, there is no proper hazardous material response team available across the island. When you ask the question regarding training, a lot of persons can verbalize that yes, they have received training doing a 2-day workshop or a 5-day workshop on introduction to hazardous material doesn't make you a specialist or an operation technician. To be a specialist, you must know the different types of hazmat suits that are required for every situation. I think you have A, B, C, D, and A, B, C, D. Yeah, let's leave it at A, B, C, D. You have different types of hazmat suits. You have suits that can offer skin and respiratory protection. You have suits that only offer respiratory protection, and you have specific suits designed for biological hazards, and they have your normal PPE type suits. So the technician or specialist must be familiar with all of these suits, because when he or her gets to the location to start designate the zones, that person's role is to determine if A level protection suit is going to be necessary, B level, C level, or D level. And if you don't have that type of training, then you shouldn't be functioning in a hazardous material situation. Now, importance of the MOI and NOI. Considering the MOI or NOI early can be of value in preparing to care for the patient. You may be tempted to categorize the patient immediately as either trauma or medical. Don't be in a hurry. So you can have a patient that had a traumatic event initially that caused a medical emergency. And you can have a patient that had a medical emergency that resulted in a traumatic injury. So they can have both, or they can have one or the other. Don't be in a hurry to differentiate if it's a medical or trauma. If your assessment is thorough, so if your fundamentals are good and you're doing a thorough assessment, you will be able to determine whether it's medical or trauma or a combination of both. All right, so we have looked at ensuring that the scene is safe. We have looked at the MOI and the NOI. Let's talk about standard precautions, which is extremely important these days, given the current COVID climate. So wear personal protective equipment should be adapted to the pre-hospital task at hand. And in EMS, it is a practice that any body fluids that is coming from the patient is considered contagious. So we take that type of approach. So standard precautions have been recommended for use in dealing with objects, blood, body fluids, other potential exposure risks of communicable disease. Should be contagious diseases. When you step out of the EMS vehicle, standard precautions must have been already taken or initiated. At minimum, gloves must be in place. Now, this is what you will discover in your textbook, so that's the answer to the question. Before you step out a unit, have on your gloves. However, let me not go there. I'm not going to go there. When we meet in person, we'll have that discussion. When you step out of the EMS vehicle, standard precautions must have been already taken or initiated. At minimum, gloves must be in place. Consider glasses and a mask. Now, the goggles and mask is definitely essential if you have to assess and manage a patient's airway. That's going to be very important. Now, apart from using your appropriate PPE, so at minimum, gloves, goggles, mask for patients with upper respiratory issues or lower respiratory issues. If you need to manage the airway, definitely goggles, mask. If you're dealing with a lot of blood, you may have to put on a gown. Might not have a lot of time to do that in most cases, so have a backup uniform, right? But if time allows, you can put on a gown if you're dealing with a lot of body fluid or blood. All right, so that's PPE. Now, apart from that, you're required to have certain vaccinations up to date to work in the pre-hospital setting. So that's a legal requirement in the States. Your measles, mumps, rubella must be up to date. you're required to have hepatitis A and B vaccine, more specifically the hepatitis B, but they give them together now. You're required to take the flu vaccine yearly, and you're required to have your meningitis vaccine as well. So these are standard vaccinations that are required to work in the US. In the local settings, so in Jamaica, it is not a standard requirement. It's not a standard requirement out here, which if it's not, you're putting yourself at risk when you go out there. So even if your organization does not make it a standard requirement, you need to ensure that you have these vaccinations up to date. Do not put yourself at risk. Now, after considering our personal protective equipment, we also need to determine the number of patients. So far, we have looked at the safety of the scene, the mechanism of injury or nature of illness, standard PPE, how many patients we have on location. So during the scene size up, accurately identify the total number of patients, critical in determining the need for additional resources. If you have multiple patients, so if you have multiple patients on location that exceeds your available resources, it now becomes a mass casualty situation. Once it becomes a mass casualty situation, your objective as the first unit to arrive, so if you're the first unit to reach that location, your objective is to begin triage. The word triage or the process of triage means to sort. It does not mean to treat. Let me repeat that. The term or process of triage means to sort patients based on their priority. It does not mean to treat. Now, my question to the group before I continue, are there any persons within the group who have completed a mass casualty training? You have been trained in mass cas. Okay. Now, a lot of persons, again, have stated that they have completed mass cas, but when you start to ask certain questions, the knowledge and understanding doesn't depict that. Now, if there is a, let's say there is a motor vehicle accident, right? A motor vehicle accident has occurred, multiple collisions, multiple patients are on that location, right? Let's say a bus is involved. A bus collided with another vehicle and there are quite a few occupants on the bus. Now, your team arrive on location. So your team has arrived and we have how many persons in the group right now? We have 32, right? So it looks like we have over 30 people on this scene to deal with. Now, let's say you go on the bus, or when you go on one of the bus, I have Mr. Allison as my first patient. So Mr. Allison is actually the closest to me. by the door. But when I look to the back of the bus, I see Mr. Washington. So Mr. Washington is at the back of the bus, and then all the rest of you are patients within the middle. So I see my closest patient is Mr. Allison, and Mr. Washington is the patient that is furthest away. And when I look at Mr. Washington, I can see that one of his legs have been amputated. So I can see that one of his legs have been cut off. My question to you is, as a group, do I go to Mr. Washington? So do I go to Mr. Washington? That is my question. Go ahead, Mr. Barnes.
No, sir.
Why not?
Because you're in the process of triage, and triage means sorting out. So you would start at the first person,
Okay, but
which
I
is
can.
closest to.
By the time I get to Mr. Washington, he's going to be dead. So you're still sticking with that, Mr. Barnes?
Yes, sir.
All right. Go ahead, Mr. Clarkson. Go ahead.
Yes, sir. You would definitely go to Mr. Washington.
I'm hearing feedback there, so I didn't hear what you were saying clearly.
Yeah, you hearing me now, sir?
Yeah, a little better. Go ahead.
Hello?
Yes, go ahead.
Yeah, I'm saying you definitely go to Mr. Washington first. During your triaging process, it would be based on priority. So if Mr. Allison, well, they clearly didn't say if Mr. Allison presented with anything severe or serious. So if Mr. Washington is the one with the amputated leg, I would consider him a priority over Mr. Allison at that time.
So when you go to Mr. Washington, what are you going to do?
I would introduce myself, most definitely. And my first instant step there would be to try and control the bleeding, because it's obvious what's taking place.
Okay, that's treating. That's not triage. You're treating. That is treating. That's not triage.
Okay.
All right, next. Anybody else have anything different? So I've heard one person state that they would go to Mr. Washington. I heard one person state that they would start at Mr. Allison. Anybody have anything different? Go ahead, Mr. Innes. Go ahead.
You heard me, sir?
Yes, go ahead.
Yes, sir. Seeing the fact that Wilmore is the first patient next to you.
Yes,
in front of
yes,
the bus. Yes, sir. On my way to Mr. Washington, I would be looking at the other patients to see if there are more severe cases to attend to before I approach Mr. Washington.
All right. So what if you bypass Mr. Allison and you see other person, let's see you see Mr. McCoy and Mr. Barnes have serious injuries. What are you going to do? This question
Yes,
is
sir.
for...
I would assign different persons from the team to deal with them accordingly.
What different person you're talking about? You're the first unit. The additional resources is not available. It's you and your partner now. So what other persons you're talking about?
Sir, my partner.
So you're gonna assign your partner, your one partner that
Yes,
you
sir.
have. Okay. All right. That's not triage. Go ahead, Mr. Roberts.
All right, hearing me, sir?
Yes, go ahead.
All right. Since we start already assess the first person, right?
No, we haven't started any assessment.
Man,
Like I said, Mr. Allison is the closest person to me. Mr. Washington at the back is the furthest person. The rest of
okay.
you are in the middle. Mr. Washington, leg is amputated. Do I go to Mr. Washington?
No, sir. I deal with Mr. Alice first, because if I continue to Mr. Washington, probably we are gonna meet up on more in between, even somebody more serious than Mr. Washington in between, and it's gonna be confusion. So we
Good.
start from Mr. Allison and try to sort out what's Triage would have be like you'd have sort out. I'm not sure. I'm just trying
Right.
to figure it
You're
out
not
from
sure
the
what it is.
lesson.
That's fine. That's fine.
Yes, sir.
That is fine. Okay. All right. I think I've heard enough responses. So the first thing is we have to understand what the concept of triage is. So the goal of triage is to sort patients based on their priority so that we can save as much persons as possible. That's the main goal. So when I arrive on scene with my unit, if I am the first unit to reach that scene, first thing I'm gonna do is contact dispatch. Hey, we're on a MVA, multiple patients. We're gonna need other units on location. Then I am going to get on my microphone. So I'm gonna get on my microphone and I'm going to speak to the persons in the bus or on that scene. Hello, my name is Ryan Rufus. I'm a paramedic with MedStar ALS Unit 20. My partner here is Mr. Barnett. We're the first unit to arrive. There are other units on their way to this location. In the meantime, if there is anyone who can hear my voice clearly and you're able to walk, I want you to exit that bus or exit the scene and go to my right over by the sidewalk. Now, what I have done at that point, if persons can move, that's your walking wounded. That's green. So I've just triaged a whole heap of people. That's walking wounded. Now, when these persons are moving, observe them. You in the green. Yes, you. That person in the black pants, yes. Gonna need your help. So come over here, I might need your assistance. Right? So that's your walking wounded. Now, when I get on the bus, if Mr. Allison is the first person I come in contact with, that's where my triage process will begin. So my triage will start with the first person I make contact with, and I will move down the line until I get to Mr. Washington. When I get down to Mr. Washington, he might not be alive. The goal is not to save one, it is to save as many as possible. Now, when I start at Mr. Allison, it is not the traditional assessment. So you're not doing a traditional assessment. A traditional assessment, if it's you and your patient, it is LOC, airway, breathing, circulation. When I get to Mr. Allison, I am going to quickly look at his breathing. Then I look at his mental status, then I look at his circulation if necessary. So let's say Mr. Allison is the first person I triage. I look at his breathing, he's not breathing, so I don't see any chest movement. I position his airway, there is still no chest movement, right? So I position his airway, there's still no chest movement. At that point, Mr. Allison is tagged as black. So that's tagged as a dead patient and you move down the line. If it was an individual patient, you would have done more in your assessment. We're not doing treatment. Now let's say I started at Mr. Allison. And when I look at Mr. Allison, his breathing, there is no chest rise. So let's say there is no chest rise, because breathing is what we look at first. I position his airway and he starts to breathe. Okay, you sir, in the black pants, come here. Just keep his head like this. Keep his head like this. And I will tag Mr. Allison red. That means once other resources are available, he must leave the scene as soon as possible. So that's a critical patient. He needs to be transported immediately. Then I move down the line. Now, that is what we call triage. So the assessment is going to be different, and the goal is to sort. So I'm going to use color cards or triage cards. I have different types. You have the red means they require immediate transport. Black would be dead. The orange mean they can be delayed. Don't remember what the white means. But triage means to sort. You're not going to be treating. And when additional resources are available, there will be a secondary triage process. So the whole a mass casualty situation and how it is dealt with is a very complicated operation. Just understand what triage means and how it is applied in the field. So it's not the traditional assessment when you have multiple patients. Now, the mental status assessment comes in if I look at Mr. Allison. So let's say I look at Mr. Allison. He's breathing and he looks as if he's breathing okay. And I start to ask him questions. You know what happened? And he's not able to clearly tell me what happened. I would tag him red. If he was able to tell me what happened, then I would look at his circulation after. But I'm not providing any type of treatment. I am simply trying to determine, is he critical, right? Is he close to death? Is he someone who can be delayed for transport? That's your goal when you're doing triage. All right. So triage is the process of sorting patients based on the severity of each patient's condition. You're preparing them for transport so that when resources are available, they will know who they need to take right away, who can be delayed, who don't have a chance of surviving. That is the goal of triage in the pre-hospital setting. All right, now after we have determined the number of patients, we definitely need to consider additional resources. So the scene size up is ensure your scene is safe for you and your crew members. Take the necessary standard precautions for yourself and your crew members. Determine the mechanism of injury or nature of illness. Do you have more than one patient? If yes, does it exceed your available resources? If you're the first unit to arrive on location, you will start triage process, which is sorting patients based on their priority. If it's one patient, you take your traditional approach. Additional resources can be hazmat, it can be specialized rescue team, it can be an ALS unit, can be a critical transport, can be medevac. So you have numerous options based on what is required. So some situations may require more ambulances or specialized resources. Specialized resources include advanced life support, ear medical support, fire department who may handle high angle rescue, hazardous materials, or water rescue. And of course, you have law enforcement. To determine if you require additional resources, ask yourself, does the scene pose a threat to me, my patient, or others? How many patients are there? And remember, if you have multiple patients, does it exceed your available resources? If yes, you now have a mass casualty situation. And it may involve one agency or it may involve multiple agencies. Right now, Jamaica does not have a mass casualty response plan. So none exists. We came close to a mass casualty situation. Well, it technically was, but it wasn't a bad one. So when that plane went down many years ago, right? So when that plane, that Caribbean airline, I think it was, went down, that was a mass casualty situation. But what saved us as a nation was there wasn't any critical patients. So there wasn't any critical patients, and that is what saved us, Jamaica, from having serious legal problems, because that particular situation was dealt with very poorly. They could, at one point, they couldn't even find some of the patients then, because bus gone with them, taxi gone with them, or private ambulance gone. There wasn't any good communication going on. So it was very chaotic, no structure to what they were doing. And if they had patients that were critical that died, we would be in serious trouble. Serious trouble. Right? So we don't have the plan in place. I'm not even sure if we have the infrastructure, because Kingston does not have ambulance response tied to the fire department. And what I think should be happening is all the various agencies should be meeting. So the JDF cannot have an exclusive mass casualty plan that only the JDF can see. The police force shouldn't have one that only the police force can see. Various members from these organizations need to meet and discuss their mass casualty response plan and how it would be rolled out, and you have to troubleshoot it. So you can have a plan and you don't test the effectiveness of your plan. So if you have a plan, every 3 months you should be running a simulation exercise to see if your plan can hold up from testing, right? What was that? You have seen a plan at, I have seen a plan at National Work Agency. So the National Work Agency has a plan. Does the Ministry of Health know what their plan is? So what's the point of that statement? How you know that Ministry of Health knows that plan? Go ahead. Go ahead. Mr. Sewell, go ahead.
Again, sir.
Yes.
As it relates to the plan you're talking about, I've actually seen that plan
Yes.
at the National Works Agency.
Yes.
What I would agree with you is that the government of Jamaica, don't really implement that plan into action. But as I said, the Works Agency has a plan, and I know other
That's
institutions.
not, Mr. Sewell, that's
Yeah.
not the question I'm asking you. Has the Ministry of Health seen and approved this plan? That's what I'm asking. You said yes. How do you know that? Where is the evidence?
Okay, sir. As I say, I'm not sure if the ministry have seen this plan, but I know.
Yeah, but you said yes when I asked the question.
All right, sir. The thing is, as I say, the government of Jamaica, which the Ministry of Health that fall under, hasn't embarked on implementing the plan. But agency across the island has their respective plan. You mentioned the JDF. I know that the bauxite industry has their plan, and other agencies. But as it relates to the government of Jamaica to implement the plan, I would say
Mr.
no.
Sewell, the government is not required for you to implement a response plan. Every industrial or organization have specific operations. Yes? So a mass casualty response situation can be exclusive to that organization. You understand that statement?
Yeah, I understand. I agree.
Good.
Yeah.
So all organizations are gonna have plan on paper, but I can guarantee you this: no simulation is being done to test these plans. And if you're going to run a simulation, the Ministry of Health needs to be involved, because you can have a plan. So you can have a plan in place and it exceeds the organization capability. I'll give you an example. So let's use Petrojam plant as an example. They can have a fire on the plant, and they have firefighters that are trained, and the firefighters can deal with the situation. What if one of the tankers explode? So if one of the tankers explode, right? What if one of the tankers explode and there are multiple persons injured? How does the Ministry of Health fits into that plan? So the Petrojam plant have a plan that they're going to implement if something goes wrong. How does the Ministry of Health fit into that? Because Petrojam doesn't have ambulance. They don't have ambulance, they have a fire response team. You see where I'm going, Mr. Sewell?
Yes, sir. I understand it clearly. And it's just when I listen to your presentation, and you show the comparison between us as Jamaica and the American standard. And I say, yes, we are. I am not here advocating on behalf of the government. Yes, we are slow in coming as it relates to the plan for the entire island. But as I say, it has to do with whatever the government see as priority in a case like this for our plan. Because as I said, Petrojam has their plan, other organizations has their plan, but how does, as the rightfully said, the Ministry of Health incorporate if it should affect the entire island?
It might not be exclusive to the Ministry of Health alone. You might need the JDF, you might need the fire department, the JFB to get involved. So we have to have multi-agency simulations.
I agree.
If you don't, you're gonna have chaos, right? And I have worked in a industrial setting where there was a situation, and because the plan that they claimed to have was poorly implemented, I was exposed, right? So I was exposed to the chemical and started to have breathing problems. So as I said, quite a few agencies have their plan on paper. Not many are testing the effectiveness of that plan. All right, good discussion. So that would be your scene size up. So that's your scene size up. We have finished the first section. Who is that? Somebody's
Mr.
mic.
Jones here.
Yes.
Sir, yes, I was just commenting on the mass casualty plan that you were asking about. There are mass casualty plans with interagencies on board, and I can speak to it. The port security committees for all the ports, Kingston, Freeport, and Noranda Bauxite has one, where we have MOH on board, JFB, JDF, JCF, Ministry of Health, Jamaica Ambulance Service, Jamaica Customs, among with other interagencies, and there are exercises and simulations that are being done every 3 to 6 months, and the government has approved those mass casualty plans.
Where is this? Which organization is this?
All the ports have it, the airports and seaports.
I disagree.
Well,
So,
I know of a few that
I
are
will
up
disagree.
and
Completely disagree.
disagree in what regard?
As I said, there is plans on paper. The effectiveness of that plan is not being tested. So you call out all of these organizations. How many of these organizations has responders that are up to date? How many of these organizations have medical direction? How many of these organizations have protocols that they're following? When you can show me that information, then we can have a discussion. Yes? So what is guiding the response in these simulations?
All right, I'll get the required evidence that you require and have it sent to you. Not sure about the medical direction, but others are there.
Right. So where the fire, if it's fire operations, I have confidence to some extent in the fire brigade. Not an issue there. If the JDF is going to get involved in terms of rescue, and I trust the medical persons in, well, majority of them in the JDF, but there are some gray areas there, right? So you having an ambulance response on paper doesn't mean that ambulance response is effective. Yes, I have been in situations working with industrial organization where on paper it is that if something occurs that exceed what we can do, then we call that company to respond. And we have had situations where we call that company more than once and an ambulance is not available. So it's on paper, people. Most definitely. Is it effective? I've yet to see that. And when I see that, I will accept it. But until, not gonna accept it. We talk, but we don't deliver. So when we can deliver, then I will accept. I have seen some horrifying things occurred. All right, so we're gonna take a break at this point. Let me see, it's 9:33. We will